Hi, welcome to Inova Talk. I'm your host, Dr. Charles Murphy. We're live streaming from Inova Fairfax Medical Campus. February is American Heart Month, and we've actually decided to do a series of heart health related topics with physicians from the Inova Heart and Vascular Institute. The Inova Heart and Vascular Institute is a leader in providing care for cardiac and vascular conditions as well as advanced pulmonary disease. There is a presence of Inova Heart and Vascular at all 5 Inova hospitals. There's also a large network of outpatient facilities, which includes access to cardiologists, electrophysiologists, advanced lung disease providers, as well as vascular specialists, and a group of outpatient imaging facilities such as non-invasive vascular testing as well as cardiac testing. Today we're going to be talking about cardiovascular diseases, chest pain, and heart attacks, and top take-home messages for preventing cardiovascular disease. Make sure you post your questions in the comment section and we'll try to answer them live. As always, please keep in mind that this is an informational session and is not intended to replace your physician's advice. Today, joining me is one of our rising stars, Dr. Behnam Tehrani, who is director of the Cardiac Catheterization Lab at Fairfax, as well as a leader of our Cardiogenic Shock team. Dr. Tehrani, can you take a few minutes and introduce yourself?
Thank you, Dr. Murphy, for having me. I am the medical director of the Cardiac Catheterization Laboratories. I've had the privilege of being in that role for the last 2 years. In my capacity, I help take care of patients that come to the hospital with cardiovascular disease. They may be presenting with chest pain, or they may be in the throes of having a heart attack, and I provide care for them in the Cardiac Catheterization Laboratories by offering them techniques using catheter-based procedures to help alleviate the chest pain and by opening up those arteries should it be needed.
Okay, super. Well, let's just dive right in. I think maybe we should start with talking about what cardiovascular disease is and the scope of the problem.
Absolutely. Cardiovascular disease is a very important condition. It affects a large number of Americans. It's the leading cause of mortality in the world. It claims up to 18 million lives per year. And in the United States, every 40 seconds, one person is going to have a symptom related to cardiovascular disease. And the one component of it that we take care of the majority of the time is coronary artery disease due to blockages in the heart arteries. But cardiovascular disease can involve not only heart disease, but diseases elsewhere in the vascular system. High blood pressure, patients that develop congestive heart failure, patients that may develop stroke, and other areas within the vascular tree of our body in which plaque and cholesterol can develop. Cardiovascular disease, as I mentioned, claims more lives than any other condition. In fact, it claims more lives than cancer and as well as respiratory illness combined. And it's expected that by the year 2035, the total cost that it will have on our health system and on our economy as a whole will be over $1 trillion in terms of direct as well as indirect costs. As mentioned, it's the #1 cause of death, in particular with coronary artery disease. And as this diagram here shows you, the heart is really a compact structure. It's the size of my fist and has arteries that line the surface of it. And when these arteries, which can be 3 or 4 millimeters in diameter, develop plaque and cholesterol over a period of time, it can result in limitations of the blood flow to the muscle, and patients can develop angina, or what we call chest pain. And if over time that becomes more severe and clot starts to form, this can result in the symptoms of a heart attack. Typically, we say that the average age for a man to develop this would be in their mid-60s, a little bit later in the early 70s in women.
But of course, if someone's younger, 30s, 40s, 50s, that doesn't at all mean that they couldn't be having
Absolutely, absolutely. So that's a great point. So cardiovascular disease is a disease that we're seeing it more and more frequently now in patients in their 40s and their 50s and even in their 30s. So it's very important at a young age to make sure that all the risk factors that can help increase the risk for developing heart disease down the road, diet, exercise, weight loss, control of the blood sugars if somebody is diabetic, smoking cessation, all of those things are managed very well early in life so that a patient does not develop heart disease in their 30s and 40s and 50s, which we're seeing more and more frequently.
I think we'll come back around to that. Maybe first we could talk about some of the symptoms and signs of cardiovascular disease.
Absolutely.
And what should someone do if they think they might be having?
Absolutely. So typically, as the plaque starts to form and it becomes more severe in terms of narrowing the ability of the heart arteries to deliver blood flow to the muscle, some of the symptoms that may start to form at the beginning are chest heaviness. We tell patients if you have chest pain or pressure or heaviness in the center of the chest, usually with exertion that resolves with rest, that's something to be mindful for and to let your physicians know. Women are different than men. Men will develop more of the classic symptoms of chest heaviness that sometimes may radiate to the arm or to the jaw or the neck. A woman, on the other hand, may develop symptoms as simple as just shortness of breath, more symptoms of fatigue that's related to exertion. They can develop palpitations, chest discomfort. And so we're very mindful, and we tell patients to be vigilant for these symptoms when they happen, especially when they're new and when they are adversely affecting the quality of their life. And these are symptoms that really should be a warning sign that a patient should seek medical attention and get further workup.
And can you give us a little sense for when someone should seek emergent or care? And
absolutely. So if a symptom is new and it's progressive and it's accelerated and it's causing significant discomfort to the point that a patient is not able to do something as simple as walking 50 to 100 feet to get what they need to do, that's a sign that you should seek emergent medical attention. Our local EMS crews are wonderful. They're able to get to the patients within a short period of time. Our Inova health system, we have a number of emergency rooms through our hospitals and also through our health plexes. And we work together through a coordinated network, and a patient is able to be triaged very expeditiously. They'll get an EKG, they'll get blood work, and then the workup will then proceed forward.
Okay. And then maybe touch some about, if I'm 40, 50 years old and I'm thinking about starting an exercise program and such, what types of screening evaluations are available?
Absolutely. So I think that, we always tell patients that especially once you hit the age of 40, it's important to begin seeing your primary physician regularly to undergo the appropriate age-appropriate screening that you mentioned. So first and foremost, blood pressure. That should be checked at least once a year by your primary physician, and to make sure that you're at the goal. As you know, the American College of Cardiology and the American Heart Association have become more rigorous with that blood pressure goal, less than 120/80. Second is to have your cholesterol checked. Having a cholesterol checked is very important. It helps give an overall assessment of what one's risk for heart disease is. The American College of Cardiology has a very nice risk estimating calculator that they put out back in 2013. And we look at that regularly when we are taking care of patients. And it looks at your age, your sex, your race, what your total cholesterol is, what your good cholesterol or your HDL is, what your bad cholesterol, your LDL is, your blood pressure, whether you're diabetic, whether you're a smoker, you're on blood pressure medicines, and that gives an overall assessment of what your risk for heart disease is. And then based on that, a determination should be made whether you should be on a statin or a cholesterol medicine. So to answer your question, blood pressure is very important, cholesterol is important, and also to have your blood sugar checked once a year to make sure that you're really not tiptoeing towards borderline diabetes, but that you're all within the appropriate range. And as part of that, it's really important to engage in a heart-healthy lifestyle. We usually tell patients to be doing exercise at least 150 minutes a week. whether that's treadmill exercise, other sorts of aerobic exercises, swimming, going on the track, rowing machine, the bike, really things to help raise your heart rate, raise your cardio aerobic activity, increase your level of metabolic consumption of oxygen, and to get your heart to where it needs to be. And I think all of those are really important, especially at the age of 40.
So, there's a whole team of providers now, physicians, including primary care specialists and advanced practice providers that are all sort of involved in caring for these issues. And you mentioned the importance of going to your primary provider to have your blood pressure checked and potentially to have your lipids checked, et cetera. When do you see the primary care physician? When should a cardiologist be pulled in?
Absolutely. So great questions. So it's really a team. It's a team of physicians, a team of advanced practice providers that are involved in the care of each patient. And initially it starts with the primary physician when they meet the patient and they get an overall assessment of what that person's risk for heart disease is. I think if that person is having symptoms, that should obviously accelerate the referral to see a cardiologist. But then there are patients that don't have symptoms but may have multiple risk factors, family history of heart disease. That's very important. Diabetes. They may have significantly elevated cholesterol levels, in particular high LDL levels. That's a sign that perhaps there may be a component of familial or genetic hyperlipidemia, elevated cholesterol. Patients that have blood pressure that may not be responding to one or two medications, perhaps what we call resistant hypertension. These are the kinds of patients that we would strongly encourage our internists in the community to consider referring them to a cardiologist and to have the appropriate workup and evaluation. Now in cardiology, there's a field developing in which there is a really close interaction and collaboration between endocrinologists and cardiologists. So it's really important that when a patient is being seen and cared for, especially with cardiovascular risk factors, all those risk factors are appropriately and well managed, and that entire team, whether it's an internist and a cardiologist, an internist and an endocrinologist and a cardiologist, and as well as with an advanced practice provider, that they work well together to identify those risk factors, really work to minimize their overall risk on the patient's overall health, and to help provide patients the most important long-term quality of life down the road. Circling
back to screenings a little bit, calcium scoring, stress tests, when are those utilized?
Absolutely. So one of the questions that's often asked is, what about a coronary calcium score to understand better what someone's underlying burden of calcium is. So heart arteries over time, when plaque and cholesterol forms, those plaques start to harden. They start to have calcification within those plaques, and that's actually a surrogate marker of underlying heart disease. As you can see here, when the American College of Cardiology put out this risk assessment tool, it breaks patients down into whether they're low risk, what we would say is their 10-year risk of heart disease being less than 5%, if they're in the borderline risk, between 5 and 7.5%, intermediate risk, 7.5 up to 20%, and obviously higher than that at 20%. If somebody is falling into that borderline or intermediate risk, and their cholesterol levels are at such where whether the internist or the cardiologist is contemplating whether to put the patient on a statin, or if for that matter the patient should be on a statin based on what their risk of heart disease is, but they may have some reluctance based on their desire to minimize how many medications they take, doing a coronary calcium score is very helpful. It's a CT scan. It essentially provides a score based on the total amount of calcium and plaque buildup in each of the arteries. And we usually tell patients that if that score is above 100, then that's a sign that perhaps consideration for early initiation of statin therapies should be undertaken. Statins are cholesterol medicines which have been around for almost 34 years. They help to not only lower cholesterol numbers, which obviously look very nice on paper as we take care of these patients, but truly at a molecular level, they help to stabilize plaque, they help to reduce inflammation, they help to reduce the hardening of the arteries, all the remodeling that happens over a period of time, which puts a patient at a higher risk for plaque rupture, clot formation, and a heart attack.
Okay. And then maybe switching gears a little bit, let's take the patient who maybe comes to Inova with a heart attack and maybe talk a little bit about the journey of what is gonna, with the quote, typical patient, what that journey through the system is gonna look like, and maybe touch on some of the strengths of Inova in terms of delivering that care.
Absolutely. So one of the things that we take pride in is that when a patient comes to our emergency room, and if they're having what we call a myocardial infarction or a heart attack, that we're going to offer them cutting-edge care, care that is really patient-centered, compassionate, and it really involves our entire care team. They will meet an interventional, they will first meet one of our physicians in the emergency room, who will triage them, get their EKG, and will call one of us who is on call that night for the cardiac catheterization lab. And then they will meet one of us as interventional cardiologists and our staff members. We have some of the best staff that I've ever worked with. They're extremely bright, very patient-centered, very compassionate. And we will then take this patient to the cardiac catheterization lab, where then under X-ray, we will then examine their heart arteries. Typically, we will access one of the arteries, usually the radial artery in the wrist. It's about a 2.5 millimeter artery. We put a small tube in there, a sheath. Through that sheath, we take catheters up into the heart, and we engage each of the arteries, and we pacify them under X-ray using contrast dye. We identify where the blockage is, and if we think it's appropriate, we'll certainly within 15 to 20 minutes be able to put a wire that's 0.014 inches through that blockage, balloon to restore flow, and put a stent. A patient, which
saves heart muscle by doing that very expeditiously.
Absolutely. So that's like Dr. Murphy, as you just mentioned, that's critically important. We usually have a metric within our health system that we want to get that artery open within 60 minutes. So from the time the patient develops symptoms until they arrive to the emergency room and they're in the cath lab, through a 2 millimeter puncture in the wrist, we want to get that artery open in 60 minutes. Time is muscle.
And it'd be remiss if we didn't mention even the pre-hospital. We have tremendous EMS teams in the area and it really starts then, so they can actually activate the cath lab from outside the hospital.
Absolutely, yeah. So we have pre-hospital activations where many times one of our EMS folks will get an EKG. They will call one of our ER doctors, and when we receive the call, the patient hasn't even arrived in the emergency room. And their 10 or 15 minutes of saved time translates into really improving the chances for recovery of heart muscle. Because ultimately, the reason why we work in such an expeditious fashion in which we really coordinate the care is we want to prevent a long-term congestive heart failure.
And you mentioned going through the radial artery or the artery in the arm to do these procedures, and I think we're up to about 75% now, and maybe you could mention the advantages and why that's a better approach.
Absolutely. So for a long time, and still in many hospitals around the country, the preferred access site is going through an artery above the groin called the femoral artery. This is a larger vessel. It could be 5-6 millimeters, and a tube goes in and a catheter goes up into the heart, and it opens up those vessels. The femoral artery, one of the issues that comes up with it, especially in the setting of acute coronary syndrome or what we call myocardial infarction or heart attack, is that these patients will be on blood thinners, appropriately so. IV blood thinners like heparin. They'll receive oral blood thinners after the stent is put in, and so this vessel may be based on its puncture site, it has an increased risk of bleeding. And if a bleeding happens in a larger vessel, it's more difficult to compress and contain. And bleeding complications translate into a significant higher rate of complications, especially after what we call a PCI or percutaneous coronary intervention, 2 to 4 times higher risk of morbidity and mortality. About 31 years ago, a physician in Canada named Dr. Campo identified this 2.5 millimeter millimeter artery in the wrist called the radial artery, in which we can do the same procedure by opening up the artery in a timely fashion without any increased risk of complications or procedural issues. And the patient is then able to sit up afterwards with a little bracelet around the wrist. And usually the patient, if it's an uncomplicated procedure, can be ambulating within a short period of time. It translates into increased comfort, reduced bleeding, and also earlier discharge.
So let's go back to the patient that has the heart attack. You've opened up the blood vessels, so then they're going to be admitted to the hospital.
Absolutely. So once the procedure is completed, based on the patient's condition, they will either go to our cardiac intensive care unit, which is a multidisciplinary unit that is serviced by a cardiologist and an intensive care unit physician, or if the patient does not need intensive care unit needs, which many times they don't, they will go to the PCCU, the progressive care unit, the progressive coronary care unit, where they will be taken care of by one of our outstanding hospitalists, internal medicine physicians who are board certified in internal medicine but provide care for patients in the hospital.
And as you say, more and more patients can go directly to the PCCU and not have to go to intensive care with a heart attack and having had the blood vessel opened up. And then the typical length of stay might be?
Yeah, so after the procedure is over, many patients will be asking for their iPhone. They'll be trying to get up and walk around, and usually with the 48 hours, patients will be discharged. It's amazing, you know, compared to where we were back in 1955 when President Eisenhower had a heart attack, where somebody could literally be bedbound for a week. So now it's literally becomes an observation level of care that they receive. The artery is opened, they're observed in the hospital for 48 hours on the monitor. They'll make sure that our team of hospitalists and cardiologists will make sure that the patient's on their appropriate medicines, and they'll be discharged in 48 hours.
And the medicines would include blood thinners if they've had a stent.
Absolutely. So we always tell patients that it's very important after a heart attack that for the first year they remain very vigilant about taking their medicines. Two medicines that are critically important. One is aspirin, which, as we know, is a blood thinner. And then a second class of medicines, of which there are a number that we can use. These are what we call P2Y12 inhibitors. These are antiplatelet or blood clotting agents like Plavix, like Effient, and like Brilinta, and patients should remain on these for the first year after a heart attack, because a stent, which is typically a cobalt chromium tube, is a foreign material, and until it's fully healed and scar tissue forms, we ask patients that they remain on these two medicines to prevent clot formation in that stent.
Okay. And then, so then I'm in the hospital for a couple days, and then I'm discharged, and maybe you could mention about the cardiac rehab aspect of?
Absolutely. So once the patient is discharged, usually within 1 week, they will follow up with their cardiologist, and then if the patient is doing well without any recurrent symptoms, if there are no other blockages that need to be taken care of, we will then very quickly refer them to our cardiac rehab department that we have here at Inova Fairfax. We have them at Inova Alexandria, and also at Inova Loudoun. There they will work with physical therapists, nutritionists, a whole multidisciplinary team of really fabulous professionals that will work to get the patient back to a higher level of functional capacity, that will work with them to really understand what their diet consists of and what they need to be doing to improve their long-term cardiovascular health. And this is an intensive regimen that's done 3 times a week over the course of 3 months.
And if, in fact, if our viewers would want to learn more about that, we actually just recently did a Facebook Live session on cardiac rehab, so I would reference that presentation. And so let's now talk, we've been through rehab and such, so maybe you could touch on what we call secondary prevention.
Absolutely. So what we tell patients is that once you've had an event of acute coronary syndrome, or what we call a myocardial infarction or a heart attack, then really the focus of our care changes from primary prevention, in which we're working on optimizing risk factors so that they don't have an event, to secondary prevention, meaning that we want to do all of the things necessary to make sure that the patient does not have another event down the road. But what we tell patients is that this is not the beginning of a new chapter in which your life is, half of what it was before. In fact, we tell patients that this is a new chapter in your life where you're going to live a better life with overall higher quality, but also a smarter life in which you're more vigilant in terms of what you're eating, how much exercise you do, being very mindful with your medications, but also being very vigilant of your symptoms. And that secondary prevention really consists of a number of factors. One is medication compliance, and we always make sure that when we see these patients in our clinic that we go over a list of all their medications so that they understand what those medicines are, what the indications for those medications are, and what the duration of time will be that they'll need to remain on them. So typically it will be those 2 blood thinners that we talked about, and after a year, aspirin for a very long time thereafter, blood pressure medicines, cholesterol medicines, with really targeted goals to get your LDL down to as low as possible, your bad cholesterol down to less than 70, and also other risk factors. So diabetes control is important, and this is where the care of the primary internal medicine physician with an endocrinologist as appropriate, working with a cardiologist is critically important, as well as other potential risk factors. So smoking. We always tell patients that the last cigarette they smoked was the one when they had was the one right before a heart attack, and our patients are very mindful and are very vigilant of that.
I wanted to circle back to some of the services that Inova Heart and Vascular provides. We sort of talked about the patient that came in with a very what I'll call a straightforward heart attack and is getting out of the hospital in a couple of days and then going to cardiac rehab. But there's another class of patients. Thankfully, it's more uncommon, but the patient that has a heart attack complicated by shock.
Yes.
And I know that you're one of the leaders of our shock team, and I want you to touch on that, and then sort of also the progression even to the advanced heart failure team, because obviously at Inova Heart we have a very strong heart failure team progressing all the way up to heart transplant or mechanical support. So maybe you could discuss that.
Absolutely. So about 8 to 10% of patients, so 1 out of 10 patients that has a heart attack, despite undergoing timely opening of that artery, being on really good medical therapy, will develop shock, or what we call cardiogenic shock, essentially a state in which the heart pump is not able to generate enough blood flow to the end organs, the kidneys, the liver, the brain. And as a result of that, the heart has a significantly impaired cardiac output. It's not able to generate this sort of timely recovery that we see with opening of that stent. Under your leadership and with Dr. O'Connor, Dr. Batchelor, and a number of other leaders in the health system, we identified this as a very important initiative. Typically, if a patient develops cardiogenic shock, survival has been around 50%, and that's despite 20 years. Since the late 90s, with the landmark shock trial of developing therapies with opening up arteries very quickly, having regionalized systems of care where patients are transferred from one hospital to the other where they can receive stenting as needed, as well as newer support devices like you had mentioned. We work together, all of us as a team, under your leadership, to bring together physician leaders from different specialties that will be involved in the care of these patients: interventional cardiologists, advanced heart failure physicians, cardiac surgeons, critical care physicians, emergency room, to identify these patients early, get them to where they need to be, to get the artery opened, get devices that may or may not need to be put in to help stabilize the heart, and then take some time to figure out where we're going to go forward. And that's where we really collaborate closely with our cardiac surgeons and our advanced heart failure physicians.
Unfortunately, sometimes the heart recovers
absolutely
fairly dramatically, and that's
absolutely
good, but then sometimes not.
Absolutely. So many times with just some time, just with a tincture of time and with a support device, the heart will recover, the device comes out, and the patient starts to undergo physical therapy, rehab, and they move forward. But then there are those, unfortunately, that don't, either because they presented late to the hospital or there was a significant history of prior heart disease, and as a result, a significant amount of heart muscle is at risk, and the recovery that we would like to see is not there. And that's where we work closely with our colleagues in advanced heart failure and cardiac surgery and start to think about, all right, so what is it going to be our destination beyond this? And we look at therapies such as LVADs, left ventricular assist devices, which are pumps that are inserted surgically in the heart and with an outflow cannula in the aorta, and patients may go home with these for several years. And whether they recover from that or whether then they ultimately may need to go to a heart transplant. And we also have some patients that have a significant heart attack in which they're in the hospital for a long period of time and then they go straight to a heart transplant. But to answer your question, it's really a journey when a patient comes to the hospital in terms of what they presented with, the care that they're going to receive. We at Inova Heart and Vascular Institute really pride ourselves on providing patient-centered care, evidence-based and compassionate care, and it's truly multidisciplinary. And we always encourage and engage all the key players to be involved, and we work together and we identify what is the next best step for the patients. Because ultimately, these are people that are important members of our community. These are people that have families, lead very important lives, and we want them to be able to get back to where they were before and to thrive.
And everyone from that interventional cardiologist that you meet in the emergency room up to the advanced heart failure cardiologist and surgeon is all part of that Inova Heart and Vascular team.
Absolutely. Absolutely. It's truly a multidisciplinary team of physicians. A patient that comes to the hospital with a heart attack will meet a number of people. And these are people that they may spend 5 minutes with, or some of them they may spend an hour with, or several days with. But these are people that will really invest their time to make sure that patients receive the best care possible, to understand why they're in the hospital, to understand why they're on certain medicines, and where the care is going to be going forward thereafter.
So now we're going to leap all the way back to this primary prevention area in a way. So I'm a 50-year-old person, I'm sort of overweight, I haven't really been exercising, let's throw a little diabetes in there and
Sure.
such. And I want you to discuss sort of the top 5 ways that people, what interventions they can make to decrease their risk of having to visit us in the first place.
Absolutely. So the first thing is exercise. A lot of people in this country, when we look at what they do during the course of a day, about 1/3 of the day could be spent just doing sedentary activities. That's outside of sleep. So just identifying how much physical activity one performs, something as simple as going to the gym in the evenings or just going for a walk outside for 30 minutes, 3 or 4 times per week can go a long way. So identifying exercise and increasing the level of exercise is critically important. Second is diet. So in our busy lifestyles, when we are tied to our phones and our email, and we're going to multiple meetings, it becomes a little bit easy to forget that it's important to have a diet which is high in protein but low in carbohydrates, saturated fat, oils, and other unhealthy content. So we always sit down with our patients and we say, all right, what do you eat during the course of a day? How many times are you eating it? When you snack, what are you snacking on? And we look at ways to help reduce the content of discretionary foods and to improve the amount of healthier portions. Third is, what is your blood pressure? How is your cholesterol? So we look at all those numbers and we say, all right, can we get those numbers to where they need to be with just conservative measures, diet and exercise? Many times we will tell somebody, if they're seeing us for the first time, is let's give you a 3 to 6 month try of intensive, what we call lifestyle modification measures. So increase your level of exercise, eat healthy, don't smoke, all of those things that we look at. If beyond 6 months we're not able to achieve those targeted goals, then we will look to see, all right, what medication interventions may or may not be appropriate. The fourth is, if somebody is in that intermediate risk and we're trying to figure out how aggressive we should be with their medications, with their cholesterol medicines, with their blood pressure medications, is to get a coronary calcium score if appropriate. Based on that, we can determine what intensity of a statin therapy medication is needed. Some people, based on where they are, they may need more aggressive cholesterol medications. We even have drugs available called PCSK9 inhibitors that are the injectable drugs, usually given for people in the secondary prevention phase after a heart attack. But based on their risk, we can do that if A, they're not able to achieve their goal with a statin, like Lipitor or Crestor, or B, if they're not able to tolerate the statin because of side effects like muscle aches or pains. And I think the last thing that we would always tell patients is really be mindful of your symptoms. So if you've really worked to minimize your risk factors, you've increased your level of exercise, all your parameters are a goal, that's great. We want you to do things and do it at a very high capacity, but be mindful of symptoms. If you have chest pain, if you have shortness of breath, if you're having symptoms that are really limiting your ability to do something you did a month ago with ease, something as simple as going out to the driveway to check your mailbox, that's a sign to contact your primary physician, be evaluated, and if appropriate, be seen by a cardiologist.
Now you covered, but I'm going to sort of also re-emphasize, like if you're smoking, you really need to stop smoking.
Absolutely.
I mean, that's critical. And if you've had a heart attack or if you've had bypass surgery, I know as having used to do bypass surgery, I mean, it was essential that the patient stop smoking. And also if you need a program, I would encourage, it's tough to do on your own, and there are programs available. I know some of these are offered through Inova that really avail yourself of the help that you'll need to be successful, because it really is critical to stop smoking. We've mentioned aspirin several times. In the patient who has not had an event, so just the 40, 50-year-old maybe has, can you talk about the use of aspirin as a preventative measure?
Great question. So for secondary prevention, I think most will agree that the benefits of aspirin are indisputable. If somebody's had a heart attack or a stroke, there certainly is a benefit. Now, what about those that have not had an event? For a long time, we had some neutral studies to slightly positive studies in terms of identifying a potential benefit in someone that may be diabetic but has never had a heart-related event. But about 2 years ago, we had 3 large trials looking at patients within a wide spectrum, either those that were moderate or higher risk for heart disease based on what we talked about in terms of the risk factors, those that were diabetic, as you know, diabetes is a risk factor for heart disease, and obviously people over the age of 70. Age is a risk factor. A man over the age of 40 or a woman over the age of 50 are at higher risk for heart disease. And what they showed was that the benefit with reducing MACE, major adverse cardiovascular events, so heart attack, stroke, heart failure, was flat, but there was a higher risk for bleeding. And so we tell patients that unless there is an absolute indication to be on an aspirin, if you're in the primary prevention phase of your life, then really we're moving away from doing that, and we'll take them off of aspirin and then focus on those risk factors as appropriate, because the data just doesn't suggest putting somebody on primary prevention aspirin without really a compelling case.
This is so much fun, and we're getting close to where we need to wrap up, but I do want to ask you, maybe comment on some exciting, most promising developments in the treatment of cardiovascular disease, and I guess at least what I'm thinking about is maybe some of the diabetes related.
Yeah, absolutely. So the field of diabetico-cardiology, as now it's being called, has really exploded in terms of newer drugs that are available. We have a new class of drugs called the SLG2 inhibitors, the sodium glucose-like transport inhibitors. We also have other drugs that are available, but this one particular class of drugs is starting to gain prominence, especially in patients that have heart failure, even with or without diabetes. And there are signs that these particular class of drugs can help reduce clinical endpoints in somebody that has heart failure. We typically think about someone taking an oral diabetic drug like Jardiance or Farxiga or Invokana if there is an indication to be based on diabetes. But now in patients with heart failure, with or without diabetes, these drugs are coming out and they're showing very good clinical endpoints. So if we have patients that have a history of heart failure if they have borderline diabetes, or perhaps not even being diabetic, we will have a low threshold to initiate these drugs, obviously working in conjunction with our advanced heart failure physicians.
Well, thank you very much for your time and expertise. Again, I would like to tell our viewers that if you have questions, feel free to put them in the comment section, and we will try to get to those even though the Facebook Live session will be over. I also want to say, if you wanted to get some simple steps to a healthy heart, there is a free heart risk assessment, and to learn more about the Inova Heart and Vascular Institute, you can visit inovaheart.org. And as always, we mention that if you need help locating a physician, please go to inova.org/physicians, or call our physician referral service at 1-855-MY-INOVA, which is 1-855-694-6682. We very much appreciate your time and your attention to our program, and we certainly hope that you'll find this information helpful, and we wish you the best moving forward. Thank you.